Bismillahirrahmanirrahim. Assalamu alaikum. My name is Dr. Uzair Ahmed. Today's topic is for fourth year BDS. This is the continuation of jaw relations. Uh, Previously, we have discussed vertical jaw relation. Today, the topic is orientation jaw relations. Basically, this is the orientation jaw relation is an accurate determination, recording and transfer of jaw relation records from patient to the articulator, which is essential for the restoration of teeth. There are restoration of function, restoration of aesthetics, and restoration or maintenance of patient's oral health. Unsatisfactory maxillomandibular relations will eventually lead to failure of complete dentures and time consuming and costly repairs, because jaw relation records lead to tooth setup, and adequate tooth setup is necessary for adequate functioning of dentures, both in the region of either the maintenance of stability, support and retention, and the aesthetics of the denture as well. So maxilla is a part of the cranium, and it is a fixed entity, and when the teeth of both jaws they come in contact, maxilla becomes related to the mandible, so that entire craniomaxillary complex is articulated with a moving bone, which is the mandible. And the whole purpose of transferring this to the articulator is mimicking all these mandibular movements and arranging the teeth and dentures in those regions in which the mandibular movements will augment the support, stability and retention of the denture. This is the anatomy of the temporomandibular joint. This is the condyle and articular eminence. This is maxilla and this is the mandible. Now basically orientation relation is, we will discuss in the next slides, that the upper jaw in the human skull is positioned uniquely to the lower jaw. This position is different for every person, and the relationship of the maxilla to the temporomandibular joint is not same in all person. That is, the anatomy of maxilla and the temporomandibular joint varies from person to person, and this is the logic behind recording orientation jaw relation. Orientation jaw relation is basically, you can if you try to understand, it is the basically a spatial relationship of maxilla to the base of the skull. The opening movement to bring the jaw from occlusal to rest position, almost a pure hinge movement, and the mandible moves on the arc of a circle with a definite radius from the temporomandibular joint. This path of the condyle is determined by the curvature of the condylar head and the curvature of glenoid fossa. This the radius is not constant for all the patient. It has to be determined for every individual patient. That is, the relationship of maxilla to opening and closing axis has to be determined. Now this is the condylar center of condyle, and mandible opens and closes according to this opening and closing axis. Now this relationship of maxilla to this opening and closing axis is basically what orientation jaw relation is all about. And its definition includes that the relation which orients the mandible to the cranium in such a way that when the mandible is kept in its most posterior unrestrained position, the mandible can rotate around an imaginary transverse axis passing through or near the condyles. It is also a functional relation between the jaws and the opening axis of movement. Hinge axis basically is the imaginary line which passes through both of condyles around which the mandible rotates. An imaginary line two mandibular condyles and the mandibular rotates without translatory movement. Here you can see that the mandible is rotating around an imaginary horizontal axis. But the pure rotation of condyles only take place when there is initial mouth opening of 15 to 20 millimeter. After 20 millimeter, the condyles basically they slide along the glenoid fossa and they translate. They do not just rotate, they begin to translate from their previous position. This movement is a combination of rotation and translation. So here you can see that in the initial first 15 to 20 millimeters, this rotation axis is stable or constant and mandible only rotates. But after that, mandible the condyle transverses along the glenoid fossa, and its axis of rotation shifts to body of rami. Then the axis of rotation will be somewhere like here, somewhere here. But in during initial 15 to 20 millimeter, the axis of rotation will be in the condyles. So this terminal hinge axis, what is the clinical use? It is the location of the transverse hinge axis serves only to orient the maxilla and to record the static starting point for functional mandibular movements. We all know that the centric relation is basically that position from where all the mandibular movements start and end. So this is the importance of terminal hinge axis. It also allows the transfer of the opening axis of jaws to the articulator so that occlusion would be on the same arc of closure and as in the patient's mouth. The hinge axis recording is required to check the accuracy of centric records, and also it helps in proper positioning of the cast in relation to intercondylar shaft. The instrument that is used to record the orientation jaw relations is the what we call a face bow. Face bow is a caliper-like device which is used to determine the positional relationship of the maxilla to TMJs or the base of the skull of the patient, especially for the purpose of properly positioning dental casts on an articulator. We will discuss all the parts of face bow now. This is some of the introductory pictures of face bow. Here you can see that maxilla is recorded according to the center of condyles, and it is joined together and then it is transferred to the articulator. Then it is now and this is another definition, that is caliper like instrument that is used to record the spatial relationships of the maxillary arch to some anatomic reference point or points and then transfer this relationship to an articulator. It orients the dental cast in the same relationship to the opening axis of the articulator. So where the articulator opens, it is the maxilla is as same relationship as in the patient. Now face bow is used in complete dentures when we have to give the balanced occlusion. In class 1 and 2 cases of Kennedy's class 1 and 2 cases, when there is open anterior bite or end-to-end relationship of the natural teeth, single rotation or on Kennedy's class 2 molar, not for premolar and first molar segmental restorations, anterior restorations, primary guidance factor in excursive movements, and restoration of entire quadrants. Diagnostic purposes and treatment planning is also some of the uses of face bow. We have different parts of face bow which include a U-shaped frame, condylar rods or earpieces, bite fork, locking devices, and third reference points. U-shaped frame is the main frame of the face bow and all other components are attached to this plane. This largest part is the U-shaped frame. It extends from the region of one TMJ to the other TMJ. Condylar rods are two small metallic rods on either side of the free end of the U-shaped frame that contact the skin over the TMJ. These condylar rods basically they locate the center of condyles, or they are used as earpieces. They are used to locate the hinge axis and transfer it to the articulator. Some face bows have earpiece that fits into the external auditory meatus instead of condylar rods. These are the basically two different types of face bows. One uses the exact center of condyle, and one uses um, external auditory meatus instead of the center of condyle, and then it basically kinds of calculates the zero error, or the uses the um, average difference between the condyle and external auditory meatus. These are the condylar rods. Then the bite fork, which is a U-shaped plate and is attached to the occlusal rims, and while recording the orientation relation, it is attached to the frame with the help of a rod called the stem. This is the place where maxilla is oriented. Now the previous ones, the opening axis or the center of condyles were being recorded. This U-shaped, this bite fork, this basically orients the maxilla, and when these two the U-shaped frame and the bite fork are joined together with the help of a locking device. This part of face bow helps to fix the bite fork to the U-shaped frame firmly after recording the orientation jaw relation. Third reference point is basically used to orient the face bow assembly to an anatomical reference point on the face along with the two condylar reference points. It varies in the different face bows, for example orbital pointer, orbital, or nasion. Now the face bows we have arbitrary and kinematic. Kinematic basically, first we talk about arbitrary, in which we have fascia type and earpiece type. The earpiece is also called external auditory meatus, and also the fascia type is where it is located on the skin. That the kinematic face bow exact opening axis of each individual patient is recorded, but in cases of arbitrary um, face bow, either the external auditory meatus or a specific point which is along the external auditory meatus is recorded for every patient. Same point is used for every patient, but in kinematic face bow, exact opening axis of that patient is recorded. Arbitrary face bow, the hinge axis is approximately located, and it is commonly used for complete denture constructions. This type of face bows generally locate the true hinge axis within a range of 5 millimeter. You have to be you are most of the time you are under 5 millimeters error of exact um, exact hinge axis of that patient. This is the earpiece type arbitrary face bow. It uses the external auditory meatus as an arbitrary reference point which is aligned with earpieces similar to those on a stethoscope, and this approximate relationship for most diagnostic and restorative procedures. Fascia type basically utilizes approximate points on the skin over the TMJ region as the posterior reference point. These points are located by measuring from certain anatomical landmarks on the face. Sorry. The kinematic face bow, it calculates or it determines the hinge axis of every individual patient. It is used to determine and locate the exact hinge axis points, and hinge axis mandible can be determined by a clutch, that is a segmented impression tray like device attached to the mandibular teeth with a suitable rigid material such as impression plaster. Now what it does is it joins the mandibular teeth to any external device which shows the center of condyle, and when the mandible moves there is formation of a certain shape over this graph which shows where the point where the movement starts and where it ends, and then when the mandible closes, this stylus moves back to the original point, and that is how a rotational axis or a hinge axis is recorded. Here you can see that over the graph a stylus is moved, and the center point of that movement is recorded as actual hinge axis of that patient. Now some electronic devices are also available to calculate the true hinge axis of the patient. Now plane of orientation is the spatial plane which is formed by joining the anterior and posterior reference points. Posterior reference points are on both sides, which can be true hinge axis or the auditory external auditory meatus. And anterior reference point can be a nasion or an orbital. In the plane of orientation, the maxillary cast in the articulator is the baseline from which all occlusal relationships start, and therefore it should be positioned in space by identifying 3 points. 2 points are located posterior to the maxilla and 1 point located anterior to it. The posterior points are referred to as the posterior points of reference, and the anterior one as the anterior point of reference. The position of terminal hinge axis on either side of the face is generally taken as posterior reference point. Now there is a Baron's point which is 13 mm anterior to the posterior margin of the tragus of the ear on the line from the center of tragus extending to the corner of the eye. This Baron's point is basically used in arbitrary phasebow, so we don't have to go into all the fuss that is needed to record the exact hinge axis of that patient. We use an approximate point which is called Baron's point, which is 13 millimeter anterior to the posterior margin of tragus of the ear when a line is drawn from tragus extending to the corner of the eye. Now this point, most of the patients, this point is within the 5 millimeter of the true hinge axis of that individual patient. Bergstrom point is 10 millimeter anterior to the center of the spherical insert for external auditory meters and 7 millimeter below from the Frankfurt horizontal plane. Now posterior points have been discussed. Why anterior point of reference? Anterior point of the triangular spatial plane determines which plane in the head will become the plane of reference when the prosthesis is being fabricated. When 3 points are used, the position can be repeated. This is basically to repeat, or you can say to stabilize the device, to visualize the anterior teeth and their occlusion in the articulator in same frame of reference that would be used when looking at the patient. The anterior point can be in orbital, is the lowest point of the infraorbital foramen. On the patient, it can be palpated through the overlying tissue and the skin. On orbital and 2 posterior points that determine the horizontal axis of rotation will define the axis orbital plane. This is the anterior and this is the posterior reference point. Or we can also use nasion. Camper's line can also be used. So moving on, how to use the phasebow. First of all, the maxilla is the position of maxilla is recorded over the bite fork with the help of impression compound. This is the bite fork, and over this a softened or heat softened impression compound is loaded, and then it is positioned over the maxillary teeth. Only the cusps and the incisal edges of teeth are recorded, and with the help of these indentations the maxillary position is recorded. Then it is removed from the mouth when impression plaster is set. Here you can see that the cusps have been recorded. If the patient is edentulous, and then instead of these teeth markings, the you can say maxillary occlusion rims are used, and they are indented in 3 points, two posterior and one anterior point, and these 3 points are recorded in the impression compound. Now this is just to give an idea of how occlusion rim can be used instead of natural teeth. When bite fork is in the intraoral position, Facebook is guided onto the stem of the bite fork. It is inserted, and then a U-shaped frame is then positioned over the patient. Earpiece, if they were using earpiece type, then it is the earpieces goes into external auditory meatus. This is the U-shaped frame. This will basically provide the posterior reference points. Orbital pointer is then located, and the calipers are, their thumb screws are tighter to maintain the spatial relationships between face bow and bite fork. Now you can see that first the maxilla was recorded, the position of maxilla, then the posterior reference point or the hinge axis was recorded, and then they both were joined together, and that's how they are related. The base of the skull, or you can say the hinge axis, is now related to maxilla. The maxillary position is recorded in comparison to hinge axis of that patient. Face bow assembly along with bite fork is removed from the mouth and positioned in the articulators. This is the U-shaped frame. This is the point where external auditory meatus, the record rods are joined over the articulator, and then the maxillary arch is attached to the upper point of the articulator. Here you can see how you can see that it is not straight, but it is the maxillary teeth are oriented in three axes, x y z axis, in the spatial relationship as according to the base of the skull or the hinge axis of that patient. Then the upper member is stabilized to the articulator, and after that this orientation jaw relation is completed. Then how the maxilla is joined with the how mandibular arch is joined with the maxillary arch, it is very simple. It is recorded with the help of horizontal jaw relation, and then the mandibular cast is easily joined to the lower member of the articulator with the help of maxillomandibular records. Maxillomandibular records are those records which are placed between the upper and lower jaw of the patient, like any kind of wax or impression compound. Both upper and lower teeth impressions are recorded in that recording medium, and then it is the lower arch is mounted on the articulator. This concludes today's lecture. The next lecture will be inshallah on horizontal jaw relations or the implants. Thank you very much.